welcome to Your Health, Your Choice. I am Dr. Roopnarine, and we are coming to you live from our studios at ACTN. On tonight's program, we'll be discussing some recent advances in surgery in Trinidad and Tobago. In studio with me tonight to discuss some of these recent advances is Dr. Yardesh Singh. Dr. Singh is a consultant surgeon at the San Fernando General Hospital. Dr. Singh is also a consultant laparoscopic surgeon, and he's also based at the Southern Medical Clinic in San Fernando. As usual tonight, guys, our numbers should come up at the bottom of your screens, and we'll do our very best to answer each and every one of your questions and comments during the program. So, guys, let's get the show going. Let's talk about recent advances in surgery, and let's say hello to Dr. Yardesh Singh. Dr. Singh, welcome to Your Health, Your Choice. Welcome to the program. It's a pleasure to have you, Yardesh.
It's a pleasure to be here, and good night.
Yeah, good.
And good night to the audience.
Yeah, Yardesh. So, Yardesh, it's myself and yourself have been discussing this field and this topic for about a month now, even before that.
Even before that.
And I know you're really excited to discuss with the public or viewers the advances that have happened in Trinidad and Tobago over the last 2 years in terms of surgery. Some of the information really didn't get out to the public because I suppose the COVID-19 pandemic kind of stole the limelight from the other fields of medicine. But surgery is something that our public is interested in, and any new advances that could benefit the patients, I'm very grateful to have you here tonight to discuss that. So in terms of the structure in the program a little bit, Yardesh, I think first of all, we should, if you could just discuss with our viewers, robotic surgery.
Okay.
Right? That's a new field that has come to the Caribbean. I know you're a pioneer in the field. You're one of the first surgeons to perform robotic surgery. So robotic surgery. And then after that, I'm very much aware that there was a world record gallstone removal done by yourself and other doctors.
Yeah.
If you could talk to our viewers about that.
Sure.
And if you could just give us a little bit of information about laparoscopic surgery, the advances in laparoscopic surgery, where it's reached now, and what newer procedures can be done laparoscopically. And if I know we were discussing that there's been a movement towards scarless or surgeries without much scars.
Yes.
If you could tell us about that, and between that, between all of that, and taking the calls from the viewers and the questions from the viewers, if we could discuss some newer weight loss surgical procedures that might be available for the public.
Sure.
All right, Yardesh, so it's a full program.
It's a full program.
It's a full program, and we have lots of wonderful slides and pictures. So I'm going to start you off with the first thing being first. What is robotic surgery? Because a lot of viewers never even heard that term before.
Sure.
What is it, and what benefits is it to the public of Trinidad and Tobago?
Okay. So when a lot of people hear the robot, there's a robotic surgery, they get a bit scared. But robotic surgery is just another form. It's the most advanced form of minimally invasive surgery that there is right now.
Okay.
And recently in Trinidad, in 2021, we actually had the opportunity to introduce robotic surgery in Trinidad.
Okay.
What does it mean?
Yes.
It means that we be able to operate on a patient and make very small incisions, do complex procedures in a very timely fashion. It allows the patient to benefit in terms of less pain. They recover quicker. They can be able to go home quicker. They'll be able to return to their normal family and daily activities. So robotic surgery offers a lot, and it has been around a while, since the 1990s. Okay. But only recently in the Caribbean. Okay. And Trinidad and Tobago has pioneered the robotic surgery in Trinidad.
Okay. So I get the idea that it allows us to do more precise surgery, right?
Yeah.
But what is the robot? What is the robotics? What is the instrument that you use? How do you do this surgery?
Right. So the robot it's a mechanical instrument that we control.
Right.
The robot doesn't do the operation.
Right.
It's a master-slave robot.
Okay.
So in other words, the surgeon is still in control of this robot.
Okay.
This robot allows us to see very accurately and under magnification the organs that we want to operate on, and it gives us control and precision to execute our operations.
Right. And this would not have been previously been possible before, or it would have been much more difficult?
Right. So previously we had laparoscopic surgery.
Right.
So it's an evolution
Of laparoscopic
surgery.
Okay.
So in laparoscopic surgery, as you know, we
Yeah.
do minimally invasive. We make the same little punctures.
Yeah.
But the robot now allows us this extra precision that
Right.
gives it back to the surgeon, where you can actually have a level of accuracy you never had before.
Right.
Because what happened before is that normally when I'm performing robotic laparoscopic surgery,
Yeah.
I will operate, I have to look at a screen.
Yes.
But my camera is
Yeah.
being held by one of my assistants.
Right.
And this may be a experienced assistant or a new assistant.
Yeah.
And they may not follow the operation. But
Yes.
what the robotic surgery, especially the cobot that we use,
Yeah.
I am now in control of my hands. I am in control of the camera. I'm
And
in
your
control of
visual
my
area.
vision.
Okay.
And it allows accuracy and precision.
Do you have any slides on it there that we could show the public? Because it might be something difficult for them to visualize.
Sure.
Um,
Can we have slide 3? Slide number 3.
all right.
Yes.
So this is robot-assisted surgery.
So this is robot-assisted surgery. So all robotic surgery is assisted because
Right.
the robot is not autonomous, meaning it's not self-functional.
The
So
robot is assisting you.
yes, it's assisting
Okay.
me. So you see me, I'm here at the bedside, but
Right.
that mechanical device that you're seeing there,
Yes.
I'm controlling it with the head device, and that head device gives me the control to move the robot to the left, to the right, to in, to out. And
Right.
but I am still in control. I'm at the bedside. I am with the patient to allow this to go on.
All right. Any other slides you have there on your robot?
Yeah. So go on to slide 4.
Right.
All right.
So that's
So next, slide 5. All right. So these are some of the advantages that we talked about. So it allows greater precision. It allows faster recovery, and it places the operation back into the control of the surgeon's hand.
right.
Yeah.
Now, when you say put the control back in the surgeon's hand, I'm very aware that how is the incisions made then? Is it that you're not obviously making the incisions? Is the actual robot arm that is making the incisions?
Oh no, the incisions are made by the surgeons.
By the surgeon.
And the ports are placed by the surgeons, and then the
Right.
robot is docked onto the port, onto the patient.
Okay.
Yeah.
All right. So it magnifies it, and that is the robot-assisted weight loss surgery as well.
Right. So this is I'm performing robot-assisted weight loss surgery here.
Right.
And in the process of actually stapling off part of the
All right.
the stomach here.
So that has been robotic surgery has been done across the world already. It's been
Yes.
out there. It's been
Yes.
utilized. It's now new to the Caribbean.
Yes.
Right. Now the big question. I mean, myself and yourself could be discussing this, and the patient at home or the public at home wants to know: is this available to them? Because
Yes.
in medicine, sometimes we talk about wonderful, fantastic things, and the average man on the street is going, is this available to me? Is this going to trickle down to me? Who gets the benefit of this? Do I have to be a multimillionaire to get robotic surgery?
Yes.
It's a difficult question for you to answer
It's not.
because of the nature of science, of medicine in this country. But tell me, is this going to be available for the general man on the street in the general hospitals?
So I've been doing, I'll just go back a bit in the history.
Yeah.
I've been doing laparoscopic surgery since 2010, 2011. So it's a long time now.
I know that.
And ever since I've been doing laparoscopic
Yeah.
surgery, I'm offering laparoscopic and advanced laparoscopic surgery in the public.
Okay.
Most of my operations, most of my advanced laparoscopic work is done in the public system.
Okay.
Public system patient doesn't pay anything, but they enjoy the benefits.
Okay.
Now, the same will follow the robot. Now, with the advent of the COVID pandemic, we had a bit of delay in introduction into the government system per se.
Yeah.
It is available in the private institutes,
Right.
but soon it will be available into the public system.
Okay. Does the surgeon have to have special training on this equipment to be capable of it? Because the first thing that our patients would ask us out there is, yes, it's all well and good, but is he capable? Is the surgeon capable to handle the equipment?
Yeah. Yes. So, as you well know, I'm also with the university.
I know.
And at the university, we are also very aware of training. Actually, I'm in charge of training in the postgraduate department at the San Fernando General Hospital.
Right. So you're in charge of training the future surgeons in the use of the robot as well?
Yeah.
Okay.
So, before we went onto this and we used this robot on real patients, we actually had to do training.
Yeah.
Now, it's first time in the world, actually, it was performed because of the COVID pandemic.
Yeah.
The proctors, the trainers couldn't fly down to us.
Yeah.
So it's the first time in the world we did remote robotic training.
Right.
And that actually it's first in the world. So
Right.
hopefully that trend will continue.
Right.
COVID has changed a lot.
Right.
So training is very important.
Yeah.
Surgeons are not allowed to operate unless they're trained and certified. So we are all certified in training.
Okay. Who are the candidates for this type of surgery? Because we've been doing surgery in this country for years on all kind of different patients, many different complexities and many different illnesses. Who do you aim to deliver this? Which group of patients do you think would benefit best with this type of surgery? So who do you market this to?
Right.
Who do you get this to?
So any patient who we can perform laparoscopic surgery on, we can perform robotic surgery on.
Okay.
Now, the robot, because it allows us a different level of precision accuracy, more complex operations. For instance, if we're doing bariatric operations, weight loss surgery operations, if we're doing complex colon cancer operation, complex pancreatic cancer operations. This is where I think the advantage of using the robot is. So while we can do the laparoscopic or minimally invasive surgery for the run-of-the-mill cases, I think the robot is advantageous for the more complex cases.
Is it because you get better access to the field? And the surgeon has better access and better control during the surgery?
Yeah, so it's a matter of having the vision and the magnification, and it allows the precision.
Okay, the precision of the surgery.
Of the operation.
All right. There's a big debate. I just want to throw this out there at you. When I looked up and did some little research, I was seeing a lot of surgeons saying it's not that much better than laparoscopic surgery. Is it much better than laparoscopic surgery?
I will say yes. For the run-of-the-mill normal laparoscopic operation, which is, I'll talk basic laparoscopy, which is laparoscopic appendicectomies, cholecystectomies. That's gallbladder surgery and appendix surgery.
Right.
The answer is it's probably equal.
Okay.
So it's probably more beneficial to do it laparoscopically.
Right.
But for the more complex cases, there's definitely advantage.
All right. Is it that the patient, I'm just asking questions that the patient might ask me as a general doctor, as their personal doctor. Is it that the surgery is a shorter time, that they're not under the knife as long? Is it that some patients with complications, like some patients who have hypertension and cardiac disease, is it safer for them to have the robotic surgery and the advanced laparoscopic surgery than going through the general surgeries? Well, are you willing to do this surgery on more at-risk patients?
Well, when you talk more at-risk patients, at-risk means it's different levels of risk you're talking about. You're looking at physiological risk, you're looking at surgical risk. It's different. So that is debatable.
Okay.
In terms of what it allows, in terms of advantage to the patient, it allows the smaller incisions, allow the operation, once the surgeon is competent, it allows the operation to go quicker.
I understand.
And the recovery to be better.
Yeah, which is a great advantage.
Yeah, get the patient home faster.
Yeah. Less stress on the body, faster recuperation, they get better quicker, less likely to get infections, less likely to develop chest infections lying on bed.
Yeah, lying on bed, exactly.
So generally after a robotic surgery, how many days is it before the patient is ambulant and walking around and go back to doing
it depends on the type of operation. When I do the weight loss surgery, they up and walking in the afternoon.
In the afternoon?
Yeah, so you're operating in the morning, by the afternoon they're up, gallbladder surgery same, colon surgery same. So you're up and moving and walking. We may keep patients back a bit because of other things, because of other illnesses and diabetes and heart disease, for safety.
Right.
My objective is not to do a robotic operation and say I send home the patient quickly. No. Safety is the most important thing, and each patient is individual. Yeah. And every time I speak to patients, I speak to them as an individual, as a person. Yeah. And I explain to them, this could be done as a same-day operation, but what do you think about it? And I give them, and they will say, well, doc, I have kids at home. I'd like to be home, doc. Yeah. I'll stay until the next morning. Yeah. And give it back to the patient, give control back to the patient.
I just comparing it like let's say I'm in practice now 20 years now, and when I was doing my surgical rounds and so on as a general practitioner, those patients that you described there, they would now get in laparoscopic stuff done. Yes. They had open cuts, open incisions, and I remember that. They'd be like sometimes a week in the hospital after the surgery. We'd have them in the ICU. We'd be keeping a close eye on them. We want to make sure the anastomosis holds. We want to make sure no infections. It was a risky game, you know.
It is.
Not risky game, but I mean, it was something that involved a lot of monitoring, a lot of work from us, the medical team.
Yes.
And I could kind of see this being, I would like to say, and you could correct me if I'm wrong, like it's even smoother, that they don't have that kind of longer downtime, they don't have that much intense monitoring by the team, there's less problems that could arise. Is that correct to say?
Well, the answer to that is yes.
Yes or no?
No, the answer is yes, because
Okay.
it has, the laparoscopy and robotic surgery has been, it is a game changer.
Yeah.
And operation, as you said, if you do a gallbladder operation, patients will be down on bed for the next 5 days. They can't go back to work for another month. But you can do a gallbladder operation, gallstones operation. Patient go home same day. I've had patients operated on a Saturday and went back out to work on the Monday.
Excellent. Wow. So I think now's a good time for us to just move directly into that gallstone operation that you were talking about. What exactly, apparently we had a world record gallstone removal.
Yes.
Let's tell our viewers about that a little bit. I mean, I'm sure they'll be interested to hear what is that world record and what happened exactly.
Could you pull up slide 32?
32 there, Josh,
Yeah. So
you could go ahead and tell us what.
Right. So this
largest.
So this operation actually was the largest gallstone removed laparoscopically in the world. Now, when I did this operation, I actually didn't realize the feat that I was performing.
Right.
Now, the patient came to me. She actually was diagnosed at the age of 38 with gallstones, and she relatively had asymptomatic. She wasn't asymptomatic, no symptoms, the abdominal pains.
Right.
However, as the years went by, and actually when I operated on her, she was in her 70s.
Wow.
She came to me and she was real distressed. And we spoke about the open operations.
Yeah.
And in terms of the open up, she went to other surgeons and they actually wanted to do a laparotomy, a 15-centimeter incision on the abdomen.
Yeah, which is the traditional
way of doing it. And I said, well, no. I said, this could be done laparoscopically. And we went ahead. It took us a little over an hour. And she enjoyed the benefits of laparoscopic surgery. Now, the incision to remove this was a little larger than usual.
Do you have a picture of that incision? Or?
Well, I don't have
maybe not.
Yes, I don't have the picture of the incision, but we have a picture of the stone.
Yeah.
So if you move on to slide 37.
Okay.
Yeah, so slide 37 actually shows the size of the stone. Now, the accurate size was 12.8 centimeters, so it's approximately 13 centimeters long by 7 centimeters
and you compare
wide.
It,
and this, compare on the left side on the green, that's avocado.
Right.
And yeah, and that's the background is on the tile. So that's the size of this gallstone. When I looked at the information on the computer and literature, I realized this was the largest stone removed laparoscopically.
All right. So let me ask you, the typical question the patient at home asking is, that's a huge stone.
It is.
How a laparoscopic incision is a very tiny incision.
Yes.
How do you get a big stone like that through a little incision like that?
Right. So the operation is performed laparoscopically.
Yeah.
But the incision to remove this was made approximately only 4 centimeters.
Right.
And I do a lot of my operation, as you alluded to scarlet surgery earlier on, and I'll show you.
We'll get into that.
We'll get into that. So I use a lot of incision at the navel area, and I could get a lot of larger structures through that.
Okay. So this came through the navel area.
The navel area.
And so how big was the incision scar you were telling us?
It's about 5 centimeters.
And you were able to get that through 5 centimeters?
Yes.
How do you manage that though?
It's
just manipulating.
It's a manipulation.
And moving it around and taking it
so it was placed in a bag, and you'll be able to pull and tug a little bit.
Right.
Now the inside incision is a little trick. The inside incision is a little larger, but the outside skin incision
you don't want to reveal the exact trick that you used to do it.
I teach my residents all the time. I teach them. Yeah.
So this was the largest this is the largest gallstone ever removed laparoscopically.
It is.
So traditionally this would have been done by the open procedure.
Open procedure.
Right. And how was the patient's recovery?
Oh, she actually wanted to go home the same afternoon.
Right.
And I told her no. I said, I think we'll keep you until the next day.
Right.
So she went home the next day.
Were you shocked at the size, or did you have an idea of the size before?
Well, I did have an idea of the size on the CT scan.
Yeah.
But didn't realize until I opened it, because sometimes when you look at the CT scan, it might be a conglomerate of stones. stones.
Yeah.
I mean, it might look like one.
Yeah.
But when I opened this gallbladder, I realized that, wow, this is one stone.
Right.
And immediately went on to the research, and we actually got a publication out of this. This was published in international literature.
Okay.
And if you go on to slide number 35.
Yeah. Slide 35 there, Josh. Right.
So this is me. I'm actually cutting open the gallbladder here, and that's the stone being delivered here.
That's huge, boy.
Yeah, that's huge. And as at that time I realized, wow, this is one. This is not. Normally you might have 2 or 3 stones stuck together, but it's not.
At that point in time, you realized it was one.
And then we went on. We got it published, and if you look at slide number 38. Knowing that this would have been a feat that the world needs to know about, we got it published in the international literature, and
very good.
Actually this spinned off onto the robotic surgery.
Very good, very good. All right, so I think now would be a good time to take a little break, right? And when we come back, we'll talk a little bit more about the laparoscopic work and moving into the scalar surgery. All right. So guys, we're going to take a little break now. I'm here with Dr. Yardesh Singh, laparoscopic surgeon. I would just like to formally invite you at this time to send in your questions and your comments to us, and we'll address it in the latter half of the program. All right, guys, so we'll see you back in one moment.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. ACTN The Voice, your family-friendly station.
All right, guys, welcome back. I am Dr. Roopnarine, and I'm here with Dr. Yardesh Singh, and we're talking about laparoscopic surgery in Trinidad and Tobago. So, Yardesh, before we broke off there, you told us about the robotic surgery.
Yeah.
You told us about the largest gallstone that was also removed in Trinidad, and that was done last year.
Yes.
All right.
No, 4 years ago.
4 years ago, which is a great for Trinidad and Tobago. It was published. Now, can you tell us a bit now, our audience at home, about laparoscopic surgery itself, the advances in laparoscopic surgery, and the types of different procedures that are being done laparoscopically?
Sure. Not a problem. Can I get slide number 2, please?
Yeah.
Slide 2.
Okay.
Right. So this is an interesting slide. So this is a slide that will help us to understand where we were a century ago and where we are now.
Okay.
So if you look at the slide on the extreme left,
Yes.
so that's a big 15 centimeter incision.
Right.
And that's the size of an incision that they would have done a century ago. We still do incisions like that.
That's for a gallbladder, right?
That's for gallbladder,
All right.
right? So that's a Cochle's incision on the right upper quadrant,
Right.
and that's 15 centimeters long.
Yeah.
Now, as time went by, surgeons and anesthetics improved, and technology improved, and lighting improved, skills improved.
Yeah.
The surgeons got better at it, and they started to make small incision to the same operation.
Right.
So this forwards us to the second clip there, which
Yeah.
showed mini laparotomy, and they know the size of the incision actually decreased
Yeah.
from 15 centimeters to about 5 centimeters.
Okay.
Now,
That might have been about, what, 20, 30 years ago?
yeah, so this is done in 1980s.
Right.
This is actually done in 1980s.
Right.
So in the late 1980s and early into 1990s,
Yeah.
technology changed, a lot of computer technology and visual equipment changed, and they introduced laparoscopic surgery. So laparoscopic surgery is very new actually in terms of the surgical world.
Yeah.
So in the 1990s, and if you look at the arrows, very, very small incisions are made. 4 small scars to
Yeah.
perform laparoscopic surgery.
Yeah.
Now, actually, when I went away to do my fellowship in 2008, they were actually performing single incision surgery, and they were performing this operation through the patient's navel, the umbilicus, and they used special ports. If you look at that last slide there, this patient had a laparoscopic surgery, and she had single incision or scarless surgery, and there are no scar to be seen on the anterior on the abdominal wall.
So that last picture there on the extreme right,
Yes.
that's the same cholecystectomy or removal of the gallbladder?
Yes. So this operation actually was removal of appendix.
Okay.
But I'll show you some more operations later on where we
So
remove
basically,
others.
the appendix, the removal of the appendix, the scar is just over the navel.
It's just in the navel, your natural scar that you have from birth.
Right. So I suppose one of the great advantages of this new laparoscopic surgery is the cosmetic effect.
The cosmetic effect.
Yeah.
Because as the skills improved and the patients, they got, it's easier for them to go home on the same day.
Yeah.
They start looking at these little small scars.
Yeah.
So surgeons actually, together with the patient demand,
Yeah.
it evolved.
Yeah, of course. It
evolved.
drives the field of medicine.
Exactly.
Yeah, patient expectation.
So
go on.
these are some of the operations that we can actually
Yeah.
perform. If you go on to slide number 10. So on slide number 10 here, these are some of the operations I actually performed first in the Caribbean.
Okay.
And these are single incision laparoscopic surgery. And I did for colon cancer, we did colectomies. So if you have right
You can
side.
just explain the terms there for the viewers.
So a colectomy is an operation where you remove the colon. And the reason you want to remove the colon is for, let's say, for colon cancer.
Right.
Patient went on to have gastrectomies.
Right.
For gastric cancers, a cystogastrostomy, that's a special one for patients who have pancreatic pseudocysts.
Right.
I also went on to do esophagectomies and laparoscopic whipples, thyroid
Removal of the
esophagus for
esophagus because of cancer. The whipples is the removal of pancreas.
pancreas for pancreatic cancer.
Pancreatic cancer, which is interesting because a lot of times in Trinidad, sometimes we don't diagnose these cancers until late.
Yes.
And the only option available is basically removal of the cancer and surgery.
Yes.
So you're saying that you could do the whipple. You could go back to the slide there, Josh, with the different surgeries. So you're basically saying that we could treat the pancreatic cancers and the colon cancers using laparoscopic alone.
surgery. Yes, we have.
All right.
We have actually performed the first in the Caribbean and went on to do a lot more.
That's great news for our cancer patients.
Yeah.
Because it means that the surgery isn't as intense because, I mean, it's really hard for someone who hasn't been in the field of medicine to appreciate that, how intense our surgeries these were 20 years ago.
Yes.
And what the risks were involved and how difficult it was to monitor these patients and how and I think anything that takes someone from cut to home quicker
Exactly.
is a fantastic
And patients,
improvement.
once they preoperatively, you speak to them and they understand what you're doing and they understand that the skill is there and they have confidence in the surgeon.
Yeah.
They actually do well.
Right.
And they can actually go home the same day, the day after,
Right.
it depends.
So-
if you could move on to slide 14, we just discuss some of the
Yeah, please.
advantages of laparoscopic surgery. So,
Yeah.
so your audience will understand why, what is, with the laparoscopic surgery.
Right, this is some of the stuff that we were talking about.
Yeah, we're talking about, you have smaller incisions, and because of the smaller incisions, you have reduced pain. They have reduced painkillers they need to take. They get better cosmetic outcome.
Agreed.
Patients can go home same day.
Yeah.
They can get back to their daily activities. They have decreased hospital stay, shorter recovery time. They get faster return to normal activities and faster return to work.
Fantastic. And the rates of success is similar to open surgeries, obviously, isn't it?
It is.
And the robotic surgery rate of success is similar to laparoscopic, or is it better?
Well,
how could you judge the rate of success? But
yes.
Is the outcome for the patient the same or better?
The outcome is the same. Okay. The outcome is the same.
All
the patient,
in terms of the removal of the
organ, but the complexity of the operation is different.
Yes.
So while I'll approach a more complex operation robotically, laparoscopically, you'll do a more simpler operation, but the outcome of the patient, you have a safe operation, and patient has a good outcome. And that's the aim for every surgeon.
I understand.
So if you look at the slide 17.
Interesting.
So slide 17 here.
So could you tell the patients what is the port?
Right.
I use the term, but they don't know what a port is.
Yeah. So if you look on the screen here, you see that there's a camera in the middle, and you have two instruments. That's my left hand and right hand. Yeah. And to get into the abdomen, we make very tiny incisions, and we introduce these little structures. We call them ports, but they have holes in the middle. Yeah. So the instrument can actually pass through the center and gives you access inside the abdomen. And through these, so I am actually operating here through the navel.
Right.
That's only through the umbilicus. So those are some. So
and where's the camera? The camera goes down.
The camera is exactly in the center there.
Right. And you watch it on a screen.
I look at it on a big screen.
All right.
So if you go on to slide 18, and this is the outcome. Right. This patient had gallstones. This patient had gallstone surgery, and the umbilicus is the only incision patient had.
I understand what you're saying.
And if you go on to
3 or 4 sutures alone.
Yeah. If you go on to slide 21.
Yeah.
All right. Yeah. So this is the same patient with single incision appendectomy. And 21.
Yeah.
And this patient had right-sided colon cancer. I did a single incision laparoscopic. Now you notice that the incisions are a little bit larger. Sometimes the specimen is a little bit larger.
Of course.
So you have to get. And if you go on to the other slide, you'll see. So this is virtually scarless. Wow. So this, there's no scar on the anterior abdominal wall. This patient had sigmoid colon cancer.
Right.
And so they enjoy. These patients up. They move. They walk. They get home in a day or two.
It looks like the patient never had surgery.
Yeah. So. And this is another patient, scarless sigmoid colectomy. Again, this colon was a little bit larger, but there's if you look just a little bit below, there's a little scar there. Yeah. Now you do what is safe for the patient.
Of course.
Yeah. So while cosmesis is important, safety is the most important.
Yeah, and I suppose, as I tell people, sometimes patients come to me and they go to see a surgeon, maybe see yourself or whatever, and I said, listen, already surgeons tell you it might be laparoscopic. There's always a chance that he might go for open procedure.
Yes.
Because something might be there that, does that still hold true?
It holds true.
It holds true, right? There's always a chance that I still believe that sometimes they need to do open surgery because they need to get their hands on something, physically get your hand on something.
There are some patients I would, up front, I will tell them, I say, this cannot be performed laparoscopically.
Right.
For whatever reason, for complexity, for the size of the lesion, and it's safer to perform it open.
Right.
Yeah.
And we had some slides there showing us like some of the actual surgeries itself. You showed us some of the laparoscopic scars, some of the specimens and so on.
Yeah. So if you go on to,
which is interesting, yeah.
Yes. Right. So
I'd just like to let the viewers know that some of these pictures might be a little bit, but it's surgery, guys. Yeah. So you're going to see actual organs with a little bit of blood.
Right.
So it might be a little bit strong for some of you with.
If you can get slide number 40.
Sensibilities, but you can put it up, Josh.
40. Right. So this patient actually had pancreatic cancer.
Yeah, that's a regular Saturday morning in Trinidad.
Yeah, regular Saturday morning in Trinidad.
Open newspapers and you're seeing that.
Yes.
Somebody.
So this patient actually, we had to do a multivisceral organ resection. This patient. This was done laparoscopically.
Just to those photos, right? Yeah.
Yeah. So we actually had to remove part of the colon. We had to remove part of the adrenal gland on the left side.
Yeah.
So multiple glands plus the cancer plus part of the spleen, and this was done laparoscopically.
All right. So that picture there is tumor. There's a cancer there on the pancreas.
Yeah.
Right?
So that's tumor on the tail of the pancreas.
Right.
Yeah.
So all those organs were removed laparoscopically.
Laparoscopically.
Right. And you got out the cancer. You took out the spleen as well.
Took out the spleen as well because the blood supply was involved.
Right.
Yeah. And now this patient recently celebrated 7 years post-surgery.
Nice.
And it was pancreatic cancer.
Nice.
Yeah.
Nice. Never knew that more.
Yeah. Could you go on to 42? Right. So another pancreatic cancer case. And if you look at this large,
Tell us a little bit about pancreatic cancer, right?
Right.
Pancreatic cancer is one of those things that really hang ahead for us in the community.
It is.
Because sometimes it's picked up late. It's very difficult to treat, or traditionally. What's happening now with pancreatic cancer? And then sometimes, the surgeon will be like, actually, it's a difficult surgery. This is years ago, obviously.
Yeah, yeah.
It's a difficult surgery. The patient might die. Everybody's worried. What's happening now in pancreatic surgery in terms of pancreatic cancer in terms of surgery?
Right. So pancreatic cancer, actually, the incidence in Trinidad and Tobago is pretty high for our capita, our population. And unfortunately, still, Robin, we pick up pancreatic cancer too late. Right. And one of the reasons for it is that there are no signs or symptoms, and when they present with the signs or symptoms, the cancer has already spread. But some patients, they actually will present a bit earlier. I've recently had a patient, she presented because she went to her GP for a normal checkup. And she got, I must commend this GP, and he examined, and he did an ultrasound, and he picked up a pancreatic.
I think we did a few of those cases.
Yes, you did.
I remember the case. Yeah.
And that was picked up because of the physician's ability to listen to their patient.
Yeah.
And we operated early, and she's alive.
Yes.
But pancreatic cancer on its whole carries a great morbidity and a mortality.
Right.
Now, in terms of what has evolved
in terms of the surgery
for pancreatic cancer, now we can do a lot of operations now, as I'm showing here, minimally invasive, laparoscopic, robotic. So the patient now, we have accuracy and vision. We have a lot of preoperative scans, CT scans and MRI that we can actually plan these operations better. So the long ago when you have to make big incisions and to perform these same operations, we can do them through minor incisions, and patient doesn't have to go to the ICU. They may go to the HDU for monitoring. They go back onto the ward earlier. They ambulate better. Physiological do better from their chest point of view and their lung point of view. We get them out to the hospital pretty
So I'm going to put you on the spot a little bit as a surgeon. How many of those surgeries would you do a year? Because pancreatic cancer is nothing common.
Yes.
It's something not that you're not going to get a lot of patients coming through the door with. How many of those surgeries have you done laparoscopically in the last 2 years? That's
right. So laparoscopically, in total, we have now performed approximately about 7.
Okay.
It's not a common operation.
No,
so we may do 1 or 2 per year.
Right.
In terms of over the years, time the patients come to you, they may be, so 1 or 2 or 3 per year, you might even do open.
Right.
So it's not a common operation.
Right.
But you can still perform them laparoscopically.
What is the most common operation you do laparoscopically in the public healthcare sector?
The most common operation, I would say, laparoscopic colon cancer surgery.
Colon cancer.
Colon cancer is very common, and it's very common. It's now getting very common in younger age group.
Okay. When you say younger age group, what age group you mean?
I'm talking about the less than 50 age group.
Wow.
And we're seeing a lot. I mean, just recently I operated on a 32-year-old
with colon cancer.
With colon cancer. No, we did laparoscopically.
Difficult pick up for the doctors because you're not expecting that.
No, you don't expect it. So long time ago, I would, a patient comes with let's say bleeding per rectum when they pass stool. I would say, well, 20 years ago, I said, this may be hemorrhoid. It's no longer like that.
Right.
I would say, no, you need a colonoscope.
Right.
And we pick up cancers.
Right. You do colonoscopies as well?
No, I don't do colonoscopies. Okay. So I work with a gastroenterologist.
Right. Sorry, go on. So you did the colonoscopy and you picked up...
and pick up the cancer,
Right. Yeah. And so laparoscopic surgery has changed the outcome for these patients?
Oh, definitely. Laparoscopic patients can actually go home the next afternoon.
Right.
Yeah. With close monitoring and
you know what I like about that is because cancers and stuff are becoming more prevalent. I don't know if there's a true statement, or is that we're becoming more conscious of it as a society and we're picking up more of it, right? But we are plagued with cancers, right?
Yes.
It is something, and we all, it's sad. But what I really like is that medicine, our field, our profession has responded.
Yes. Yes.
We responded to it, and we become better at the surgeries, become better at the treatment.
Yeah.
You know what I mean? We didn't hang down and wait for it. We responded to the cancers, and we have better treatments, better chemotherapies, better surgeries, better preventative medicine, better diagnostics.
Yeah.
So that's what I really like. So you could go on and tell us a little bit more about any other surgeries that you would do laparoscopically, and what other types of surgeries you've done with the single port or the scarless surgery?
We did scarless appendectomies, gallbladder surgery for gallstones, colectomies for colon cancer, bariatric surgery, weight loss surgery,
but we'll get into that
metabolic surgery, which is for type 2 diabetes.
We could get into that after.
Also for rectal cancer surgery, pancreatic cancer surgery. I've also done laparoscopic surgery, because in the center I trained on cancer of the esophagus and stomach and the GI system.
Right.
So, and I brought back that technology here in terms of the laparoscopic surgery, offering it in the general hospital.
Very good, very good. All right, that's I think we hammered you a little bit there with the laparoscopic stuff. You explained a lot. We're going to take our second break, and when we come back, we're going to try and take some feedback from the audience, and we'll probably have a little discussion on the bariatric surgeries as well, the weight loss surgeries. All right, guys, so you could send in your questions for Dr. Yardesh Singh, and when we come back, we'll try to answer them for you. Take care, guys. 1 minute. All right.
Yeah.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. ACTN The Voice, your family-friendly station.
All right, guys, welcome back. Your Health, Your Choice. I'm here with Dr. Yardesh Singh. Please send in your questions if you want to find out any information on laparoscopic surgery, if you have any questions on robotic surgery, and on weight loss surgery. So, Yardesh, tell us a little bit about bariatric surgeries, weight loss surgeries. Right. Who are the patient candidates for this? How long has it been done in Trinidad and Tobago? What were the traditional methods? What are the improved methods available?
Right. So in terms of the candidate, I mean, how the surgeries perform is laparoscopically.
Right.
And now we can
Ever since?
Well, no. Initially in the early 1970s and 1980s, it was open.
Right.
And that's the open era.
Right.
But as laparoscopy came into vogue, it has been done laparoscopically, and actually in the beginning obesity was actually a contraindication for laparoscopic surgery. Now it's a big indication. All right, it's one of the number one operations in some parts of the world, like in the US and Canada and stuff like that.
Right.
So what type of operations do you offer? You could offer a simple sleeve gastrectomy, which is...
Who's the candidate for bariatric surgery?
Right, so in terms of the candidate for
So somebody comes to you, Yardesh, and they say, look, they're interested in having... I go to you, right? I put on a bit heavy. I say, Yardesh, I want to have weight loss reduction surgery. Right. How do you take us from there?
Right, so it depends on the patient. So the criteria for a bariatric weight loss operation is very specific.
Right.
Now, we don't do it for the run-of-the-mill patient who is overweight.
Yeah.
So a patient has to be of what you call the body mass index.
Yeah.
So a body mass index above 35 or a body mass index with a medical problem or above 40.
Right.
without any medical problem. So body mass index is your weight on your height ratio.
Exactly.
Right. So most patients who come, they
Would be a BMI greater than 40.
right. So greater than 40. 48 is the average.
Okay.
They will come to you. And patients like these would have gone through a lot of diets,
Right.
a lot of fat diets. They will yo-yo diet, and they will lose weight, and they're good when they do it.
Yeah.
They will lose 50 pounds, sometimes 80 pounds, and they will be good for a few years, and they put it back on.
Right.
Some patients would have gone through pharmacotherapy, or they take tablets. Some patients would have gone through behavioral therapy.
Yeah.
Now, once I have a candidate like that, and I assess them, and I said, look, you have really tried.
Yeah.
You know, and they have gone through all these things, then
Yeah.
they become a candidate. Then we have to assess them properly
Yeah.
to make sure that they're fit for the operation.
Right.
So while weight is a factor, you must have gone through things like diet and exercise and those things before you really become a true candidate. Because a lot of things about the weight loss surgery, it's a lifestyle change. The operation could only do so much. And while in the beginning, the first few years, yes, you enjoy it a lot and you enjoy the benefits. Your lifestyle has to change, your eating habits have to change, you must diet properly, exercise properly, and you continue to enjoy the benefits of bariatric surgery.
So bariatric surgery, right? It's I've heard people saying that, listen, it is an option for diabetics.
Yes, it is.
Why is it an option for diabetics?
Right. So what,
Does it cure diabetes?
yes, as a spin-off benefit, from bariatric surgery. Actually, the guy name is Walter Porres,
Okay.
and he published a paper. Who would have thought? In other words, who would have thought surgery would have been the cure? And
Yeah.
he
Would have
showed
thought medicine would have been a cure. Right?
yeah, a tablet is the cure.
Yeah.
And what he showed that patients who undergo bariatric operation, may it be a restrictive, a sleeve gastrectomy, or a gastric bypass or mini gastric bypass, they all enjoy a similar benefit. They have about a 70 to 80% resolution of their diabetes. And some patients even come off all their medication before they leave the hospital.
Wow.
And it was really amazing, and there was so the initial societies were named the Societies of Bariatric Surgery. Now, because of this big change, the societies have changed and named to Societies of Bariatric and Metabolic Surgery,
Right.
meaning type 2 diabetes, hypertension, hyperlipidemia, all these things change. Now, it's very
That's a
important.
big point there,
Yeah.
That's a real huge point, because what you're trying to say is that the surgeon is making the medical practitioner obsolete, yeah?
Well,
Because
no,
I mean,
no.
what I mean by
Yeah.
that is, you're saying that there's actually a way to treat chronic conditions sometimes, that the bariatric surgery
Yes.
has helped these patients with chronic medical conditions.
Chronic medical conditions,
Not just
right.
the diabetes, but the hypertension as well. So is it that, what is the typical age group for the patient that has this? Is there a cutoff age group, a cutoff age? I mean, would you offer this surgery to a 70-year-old or 80-year-old?
I personally know.
Right.
I would not offer it to a 70. I mean,
Right.
the young adult,
Yeah. Yeah.
a fit, healthy older person. But I would, and venture into the age of 70, you're putting patient at risk for an operation that would maybe benefit them in the short term, but in the long term, maybe not.
All right. So can you tell us the different surgical procedures that they are?
Right. So a lot of operation, they concentrate on the stomach and the small intestine.
Right.
So one of the most common operation we do is, actually the most common operation in the world right now is the laparoscopic sleeve gastrectomy.
Right.
And it's actually one of my personal, I like that operation best. Reason being, it's a physiological operation. And what I mean by physiological, we don't interfere with the patient gastrointestinal system. So what the operation simply does, it makes the stomach into a narrower stomach.
Okay.
So we literally remove approximately 85% of the stomach.
Right.
Now, we do that under guidance. We use a tube sizer.
Right.
And so we accurately know what size we put per patient.
Right.
And patients enjoy weight loss. So
Okay.
now, in terms of when you eat, it goes into the small stomach. You can't eat plenty, eat a small amount.
Yeah.
But it goes through your normal GI
Digestive
system.
process.
You'll be able to absorb your vitamins, your mineral, your fats, your proteins. Now, another operation is the bypass operation. It's a very common operation. A lot of patients will come and they will request the bypass operation simply because they did research. And I offer both. Now, in the bypass operation, what we do, we separate the stomach into two. So the food now has to get into the small intestine. So we actually bring up a piece of the small intestine, we join that back up.
Right.
Now, that it's exactly what it said. It bypasses. So you bypass about 200 or 300 centimeters of your small intestine.
Right.
And there's a part of the stomach you don't ever get access to again. Because if you do, when you go to gastroenterology, you have to do endoscope and put it into your mouth through, into your stomach.
Yeah.
You can get into small intestine. But now, there's a part of the stomach that you can't get access to. So you may have gastric ulcers, tumors, whatever it is.
Right.
But it's a popular operation that has been tried and tested.
Right.
And it works.
Okay. So those are the two major types.
Those are the two major types.
Right.
There are many other types of variation of these.
Right, but those are the two major types that you're familiar with,
Yes.
that you do commonly. And this is done laparoscopically as well.
This is only laparoscopically.
Right. Is this available private and public? Or?
Yes. So initially we started offering it in the public system, but that quickly came to a stop because of the volume and the demand in terms of, because it takes a lot of equipment.
Yeah.
And we actually do it in select cases now.
Yeah. Do we do a lot of that surgery in Trinidad? Is there a huge demand for it?
There's a huge demand for it. So in the
because of obesity?
Obesity, yeah. So obesity is a common thing in Trinidad, overweight and obesity.
Right.
And what goes with it, the comorbidities, as you know, the type 2 diabetes and hypertension, hyperlipidemia, the osteoarthritis, the obstructive sleep apnea.
Right.
So we have a lot of those things in the country. But so, yes, it is a common operation.
And after the operation, let's talk about the aftercare after the operation, right? After the operation, what's the patient like? They forever could only eat a small amount of food, or it causes weight loss by a reduction in their capacity to eat.
Yeah,
Isn't that right?
Two ways. One is it restricts what you can eat. So one is the volume that you eat.
Right.
So a dietitian is a cornerstone, a key element in your bariatric. So it's not the bariatric surgery and you're done.
No.
So you have a bariatric surgeon. You have your
so you have a team of people with
team of people. You have your endocrinologist.
Right, of course.
You have your dietitian, and plus or minus sometimes a psychologist.
Right.
All right, but it's a team of doctors that work together. Now, the dietitian is a cornerstone and it's a lifetime thing for these patients. So they have to eat healthier. They have to take in a certain amount of proteins per day, make sure they take the vitamins, mineral supplements.
Regardless of whichever procedure
Regardless of whichever operation you do.
Right.
So
lifelong.
Right. As I told you in the beginning, it's a lifestyle change.
Right. Have you ever had many patients regret doing the operation? Do patients? I mean, it's a hard question for me to ask you, but it's a question that somebody at home would ask.
I've never had personally a patient who regretted doing the operation.
I mean, Trinidadians love food, right?
Oh, from that point of view, no. From an eating point of view, no.
So it's just that they can't eat the quantity and it goes down.
Yeah.
Has there ever been a patient, and so not have you ever, but is there patients or circumstances where there's a failure of the surgery and people put back on weight afterwards?
Yeah. So if you look at the worldwide data, looking at the worldwide data, about 20 to 25% of patients will put on some form of weight. And there are centers that actually specialize in revision bariatric operation. So yes, and it's for various reasons. One is in terms of the patient may not continue on with their program in terms of their diet, and calories can be taken anyway. You could take liquid calories, and you could take 10,000 liquid calories instead of eating. So it's a combination. It's not always the patient, but sometimes it's sometimes the procedure itself. Sometimes the stomach may get redilated up. Sometimes the where you do the joining in the intestine, that actually gets a bit larger. So the human body adapts. It adapts.
And is it that there's a faster passage of food through the system as well? Do they have to use the washroom more often than normal?
Yeah, so it depends on the type. So in the sleeve gastrectomy, the answer is no.
Okay.
But in the bypass operation, yes. So the frequency of stool is increased. Some patients who have more complex operations, there's another operation called the biliary pancreatic duodenal switch. It's a big operation, complex operation, as you know. But these patients have what they call malabsorption. So they meaning that they don't absorb anything. So their fats go into the stool.
Can I ask you, how much of these surgeries do we do? How many of those surgeries do we do a year in Trinidad and Tobago? Because it is a fairly new field still.
It's a fairly new field.
Is there any data? Or
not really.
Because everybody just does their own?
Yeah, it's more independent.
How much of these would you do, if you don't mind answering that?
Yeah, so probably about 30 to 50.
Okay. A year?
Yeah.
Okay, that's fair enough. Yardesh, we've come to the end of the program.
Yes.
The hour has flown by. I think it was really educational.
Yes.
I think it was very important to put out the information of what is happening in surgery in Trinidad. Very important for our colleagues as well, because a lot of our colleagues might not have been aware of how the little extra leap that we have made in laparoscopic surgery and in robotic surgery. And it would also, the information would also give the patients at home a little bit more confidence. And those people that might be scared of surgery, or the word surgery, might feel a little more at ease knowing that it's not as rough as the traditional forms, or might not be as rough as the traditional forms of surgery. And anything that could reduce fear and increase hope is a great improvement in surgery in Trinidad and Tobago.
Yeah.
And two things. One, I thank you for doing and being an active participant in this advance in surgery and driving it and being a part of it and leading it, because that could only benefit our patients. And two, thanks for always answering your phone and helping us in Marabella.
Yes.
and seeing all our patients in San Fernando.
Not a problem.
And thank you very much for coming on the program tonight.
Sure.
It was a pleasure to have you.
Yes, and I would like to also thank you, Robin, for having me here and for helping to educate the public on the new advances in surgery in Trinidad.
All right. So guys, thanks again to Dr. Yardesh Singh, and thanks to each and every one of you for tuning in tonight. All right, guys. So God bless. Take care. Have a pleasant evening, and we'll see you again next week, guys. Take care.